Thanks very much for joining us today, Sandrine. Without further ado, can you give us a brief introduction of yourself and your background?
Yeah, so I'm Sandrine Aspeslagh. I'm a medical oncologist. I did my PhD in immunology at the rheumatology lab, and it ended in 2012. And in 2012, ipilimumab was granted by the FDA to be given to melanoma patients. So it was the first time that immunotherapy was really applied into cancer patients, and that made me decide to choose for medical oncology as a specialty. And I also liked to take care of cancer patients. And then I worked 1.5 years at the Ghent University, but I didn't see enough patients with immunotherapy, and that's really what I wanted. I still have this passion, so that's why I went to Institut Gustave Roussy, and I worked there about 3 years with Professor Marabel and Professor Jean Soria at the phase 1 unit, where at that time all immunotherapy trials came out, and we also saw for the first time how the toxicity, so when you boost your immune system, what is happening. And those patients were, it was like back to rheumatology clinic, because I saw a lot of side effects, and that's also why I'm interested at. And then I wanted to come back to Belgium. I worked a year in Institut Bordeaux, and now since 4 years I'm working at the UZ Brussels. So that's Dutch-speaking hospital in the area of Brussels.
What inspired you to get involved in immunology in the first place? Where did the interest in that prior to the...
I think it's quite holistic. So it's the role of the immune system is to keep balance of the body, and I think really I like this. I like the balance, and I like to try to keep the balance. And I read a lot of papers by Dr. Metzitov about that as well. And I think that's really fascinating. And with the immune system, you can keep, it can treat infections. When it's too much, it's autoimmune disease. And yeah, it's really this balance of our body that fascinates me. Yeah.
Very interesting.
Okay. And Sandrine, could you give us an overview of your work in immuno-oncology and specifically in IO toxicities?
Yeah, so during my first years, I mainly did, when I did a PhD, was mainly basic biology, which was an ideal basis to understand what was going on. And then later on at Gustave Roussy, I also worked on biomarkers, but now I'm mainly focusing on immune-related adverse events. And what I've done until now, I think the main thing is really building this network. So because it's rare events, because oncologists were not used to treat those patients, I think we have to unite, and we have to bring oncologists first together and together with organ specialists, so that we can deal with these severe side effects first for the patient to find the best solution so that they don't suffer. But second, also for science, and science both for the oncologist, but also for the rheumatologist or the pneumologist, who will then better understand their disease, if I can say so, because our patients are kind of human models for them. So you can, when you have an encephalitis due to anti-PD-1, you can study the role of PD-1 in encephalitis, and does it play a role or not? And I think this is really the future of collaborating, and that is what I really like about it. So and in the future, we want to focus on prevention and on therapy by several prospective trial options.
Could you explain how it relates to rheumatology or the side effects associated with IOs in oncology?
Yeah, so sometimes we only give 2 injections of anti-PD-1 or a combination, and you already see an arthritis. And then you know that this arthritis is really anti-PD-1 dependent. And also autoimmune diseases are mostly chronic diseases. So most of these patients, they have it lifelong. Whereas our patients, they have it only for a short time. Most side effects are short time, and we can stop them when we stop the immunotherapy, or it's true there are long time side effects, but there are also short time, like a colitis. You treat it 2 times with a TNF blocker and it's not coming back. Well, that's a bit of generalization, but it might be like that. And this is not seen in Crohn's disease. And there's more and more in the autoimmune field also to try to find a complete response. So, I mean, to cure the patient from, for example, Crohn's disease, but maybe our patients are kind of cured of this colitis. So that could be one example where organ specialists can learn from more patients, actually. Yeah.
Okay. And I guess it's just the trying to do something to fix the side effect, the colitis or whatever it may be, is something that can be taken and learned by the
Yeah,
rheumatologist.
or to look at our pathophysiology, for example, or to look at when you do a biopsy to see which cell plays a role and to what does it resemble. I'm really convinced that a lot can be learned from us. I really believe that we need to work together and that we are stronger together. That is my main message.
Yeah, very good. And could you tell us a little bit about the kind of collaborations and how it works in Belgium, in terms of the various groups you've set up?
Yeah, so BTOX, that's how we named our national multidisciplinary board to discuss immune toxicity and disimmunity patients. So patients with a severe immune-related adverse event can be discussed there, or patients that have an underlying disimmunity. And what do I mean by disimmunity is, for example, an autoimmune disease, but it can also be a patient that had already a severe immune-related adverse event and where you think, can we restart or can we not restart? Patients with paraneoplasia, patients with a hematological malignancy, and so on. And those cases are discussed together with organ specialists. And we have currently we have a meeting every 2 weeks on Mondays. And in order to be part of this, you have to send us an email and we put you on the list. So it's not accessible for everyone because it's a delicate patient information. So we can control that. And then after the discussion, where we invite organ specialists, for example, when there is a patient with a polymyalgia rheumatica, then we'll invite a rheumatologist to have his or her ID. But it's always in collaboration with the oncologist, because we cannot just leave our patients in the hands of an organ specialist and that they organize everything. No. We really have to this balance again. And that's what I also mean earlier, because it's also, what's going on with the tumor? Is the tumor disappearing? Is it coming back? It's a partial response. How can we, or maybe there's another therapy possible that is now more chance to answer. So it's quite complex discussion, but I love that. It's really interesting. And it's true, it has been a challenge for the last 2.5 years. So now we've discussed 170 patients. It's a challenge to bring all these doctors together because we all have a lot of work. So I try to, there's like a Qualtrics, or it's kind of a red cap formula, and they have to fill in. It's very short, very few information, only takes 2 minutes. And then this is sent to us. So we have basic information. We did basic information. We then contact the organ specialists so that they are prepared. But it's not always easy to find interested organ specialists because they do not always have time. It might not be their good time schedule. So that's a kind of challenge, to keep them challenged as well, to keep them interested. And but we're getting there, I feel.
And in terms of, I suppose, those 170 patients, like, is there a wide variety of different, do you see a wide variety of different toxicities, or is there a common thread?
No, it's a wide variety. I would say that like a third is on disimmunity and the other 2/3 is on the immune-related adverse events. There's a lot of neurological and cardiological toxicity because those are also the most complicated ones. I would say so. And there's also more questions on double IO versus mono IO, but that's quite logic, I think, because there's just more tox. So that's about it. But it's very variable. It's every week it's different. Yeah.
Okay, great.
Very interesting.
I would imagine there's a lot of interesting research comes out of that.
Well, I think now we're getting there. So, but that's a bit a GDPR issue. So we are trying to solve this. We have contacts with the Belgian government so that maybe we need a change in the law or something. We try to work with the pharmacovigilance of Belgium, but that's a challenge because I agree that it's a big research data, and it would be really interesting also to follow up on the patients. So because now we just discussed the case on day one, but we do not know if our advice has been followed or if it has helped and what has helped, because we want to learn from this. That's also the idea. So we're working on this. Yeah.
The longitudinal data.
Exactly. But that's also GDPR. I mean, we really need to find a way that it's GDPR proof.
Yeah, I think a lot of physicians in Europe are finding the same challenges in terms of GDPR.
Yeah, I guess I'm not alone. Yeah.
No.
Could you tell us about your current research and its relevance to IO toxicities?
Yeah. So with Marthe Verhaert, that's my PhD student, we've set up a research program which we call DYTOX, DYTOX. And this contains mainly 3 parts. So the first part is FORX, where we try to do prevention with food strategies, and I can come back on that. And then the second part is improve, where we want to treat, when we want to find out treatment strategies for severe immune-related adverse events, because that's all the problem. There's no research on this. It's all rare. Everybody's doing something in his own hospital. And that's what now with BTOX, we have a good fundament to change that. And then third, we do real world evidence. So we were looking at a population of patients with cemiplimab that was used for spinocellular carcinoma of the skin, because they have a lot of underlying disimmunity problems. They're often very old. They have sometimes immunosuppressants. They sometimes are transplant patients. So we're looking at a big cohort in Belgium, and that's the current plan. Yeah.
Okay, great. Could you tell us a bit more about FORX?
Yeah. So FORX, it's a food intervention to reduce immunotoxicity, and our first FORX trial we hope to start as soon as possible. We're writing up the protocol. It's based on a research of the American Gut Project, where it was shown that when you eat more than 30 different fruits, vegetables, and nuts, that your microbiome is more diverse versus if you eat less than 10. So our idea, and we know that the outcome of immunotherapy is better, at least this has retrospectively been shown, if you have a diverse microbiome and if you eat more fiber. So this is why now we thought, let's just do this, and we're really motivated, and we want to give at the start of the immunotherapy during 12 weeks, so until the first scan, we want to give a box with 30 different fruits, vegetables, nuts, and grains, so all plant-based, but diverse, so that there is a diversity, and we will have a dietitian that will motivate and help the patient to eat all this within 1 week. It's a challenge, but we get a lot of positive reactions from the patients as well, and that's also it came from the patient, this idea. I mean, from scientific literature, we cannot advise a lot because nobody is doing these studies, and if our study is positive, because the goal is that we reduce immune-related adverse events by 20%, and if this goal, if we can reach the goal, then we can say to the patient, you know what, just eat 30 veggies per week. And we want to work with cooks to have like a cookbook. And I mean, you can do a lot and make an application and whatever. You can do a lot of things around it. But that's really the idea, to give the power back to the patient, because this will also improve quality of life. Instead of saying, no, you can't do anything, we really want to say that, no, you can do something. The job of the patient, if I can say so, is to deal with their body, and our job is to give the right medication. But I really think you should give a task as far as it goes. I cannot exaggerate on that, but that's the idea. Yeah.
Okay. You mentioned there about the positive nature of giving them a pack. People's diets vary quite a bit. I just want to understand why they take it so positively. In some case, I would have thought there would have been a negative reaction to asking them to change their diet.
Well, that has been proven. When the moment that you receive the message that you have cancer, it's really a moment where you want to change your life. A lot of people quit finally smoking when they get the diagnosis, often of lung cancer. But so there is this thing, okay. And also giving the power back to the patient often will help. But I agree that there gonna be patients, and there's nothing that fits for all. So there are always gonna be patients that say like, no, I don't want to change my diet. Okay. But for our study, we're looking for motivated patients, and I'm sure that we will find them.
Okay.
In the population that I see, I ask often and I talk about it, and most people are very positive about it. Like, oh yeah, I'm happy that I can do myself something.
That's great. Yeah.
Yeah.
Yeah. And you're currently running a crowdfunding campaign for that, am I correct?
Yeah. So we asked regular funding, and we're going to the second round of the Kom op tegen kanker. But yeah, if we get that, we can only start in March 2024. So that's like 1.5 years after the start of our first idea, because it takes so long to write all these grants and whatever. And if we do now crowdfunding for 12,000 euros, because then we can already start with 10 patients. And for us, because there's a lot of logistic, there's a lot of new, it's not just giving a medication, no, it's finding out all those boxes, logistically, how are we going to deliver them? So if we could start with 10 patients already in autumn, it will really help us to be up and running when we get all the money to then quickly continue, because yeah, I'm sure we need some time to find the best way to do this, because it's a real challenge. It's completely new to do that. We are not used to do that in our hospital. But in Institut Gustave Roussy, they are doing keto-rein, and that's a ketogenic diet in kidney cancer patients. So
oh, wow.
Yeah,
okay.
There, but and also in Texas, there's also a trial, but I don't have the name right now. Also for immunotherapy, but in Belgium, no, that's the first thing we do, and we also we take a risk by not making it too much control. So the food boxes are not going to be the same every week. They're going to be seasonal. So if it's broccoli season, okay, there's going to be a broccoli. If it's salad season, well, you know, I mean. Yeah, that's part of normal life. So
yeah,
we really wanted to keep it so close as possible to reality. Yeah.
Is it so? You're sourcing the food kind of from the local area of Belgium?
Yeah, that's what we would love to. And we are still discussing on this, because also for them it's very new that the medical oncologist is approaching them and saying like, hi, we want to work together. They're also like, oh, yeah. So that's very new, yeah, we would love to do like there's a community supported agriculture behind us, a courgette, and it's really on the field of the VUB. So that's my the Vrije Universiteit, that's my university. Yeah, that would be really perfect. I mean, it's like 100 meters.
Yeah.
Very good.
Let's see what works, and we might not have everything in 100 meters, but I mean, yeah, that would be really, really, really cool. Yeah, I would love it.
You know, it's something I've read quite a bit about, and you know, watched documentaries on, but you know, about local food and the benefits of it. Is there any academic evidence there? Is there any scientific evidence for that, or is it just still something that is in research?
Well, not that I'm aware of, but at least the carbon print is less. You don't need a plane, you don't need a car. So that is better. What would also be nice if it's so close that our patients, they could have a look there. They could have a look where their food is grown. And this is, of course, it's a bit outside the project, but it's also, bringing back patient or people to nature and bringing back the basic. And yeah, that's something really nice, I think. Yeah. I'm sure this will also help quality of life, but that's not a direct part of the project, but I would love it when it would be associated. It's not that it's better for your microbiome that you eat local food. There is something about honey about this, that it's better to eat honey from your local bees. That you would, Yeah,
okay, great. And we'll make sure to link to the crowdfunding campaign as well in the show notes. So if anyone's listening to this, they can definitely click on that and contribute.
Yeah, for Belgian citizens, it's tax deductible. So if you give more than 40 euros, then you can deduce this from your taxes.
Okay, brilliant.
Okay, brilliant.
And what motivated you to investigate this area, to, you know, the food and the IO toxicities? What was kind of your inspiration behind it?
So yeah, the talks with the patients, and then also my personal interest, and maybe the first 7 years of my life I didn't eat gluten. I couldn't digest gluten, so maybe I also realized that, or it's in my DNA or something, that I know that you can change your life and your health by just what you eat. I'm really a very strong believer of it. So
Very
Okay,
good.
great.
And regarding the work in high fiber diet, what is the specific objectives and expected outcomes?
Sorry, for FORX?
Yes.
Yes.
The objective of FORX is to reduce all immune-related adverse events by 20%. So if we look at big phase 3 trials, it's often 80%, but that includes the itching, the fatigue, so the less obvious immune-related adverse events as well. And we want to reduce that by 20%, and we'll compare to historical control. We cannot, in Belgium, we discussed a lot with patients, and they say that if you would do a 2-arm trial where you randomize versus placebo, all the patients we ask, they say, but then I don't participate to the trial if I'm in the placebo arm. So yeah, we were kind of, and we asked more than 10 patients. So yeah, we're not able to do like a randomized trial. And so then we discussed a lot with our statistician, and now we'll treat 60 patients, and we have a big historical control, because at the moment we are doing IKIT, that's an observational trial where patients that receive immunotherapy, we do like an immunomonitoring for them. So we have a lot of data on them, and so they will be the historical control.
Yeah, great.
Okay.
And as the field of oncology continues to evolve, how do you see microbiome research shaping the future of treatment strategies and patient management?
Yeah, so I can imagine that in the future that we do like you do a blood test, that you also do a microbiome analysis, and that once we will know more about the microbiome, because we know a lot already, but we cannot, as far as I know, it has not been proven that you can really predict that it's really standardized, and that you can predict based on the microbiome if the patient will respond or not, if they will have toxicity or not. But I believe that in the future, like in breast cancer, I can't find the name, but there is like there is a test where you can see what is your chance of responding to chemotherapy. I think the microbiome will play a role in that. So and I think in the metastatic setting it's maybe less interesting, but in the adjuvant setting this might be really interesting, because yeah, I come back to that balance. The adjuvant setting, it's not always super clear if you really need to give. So some patients, you give them the immunotherapy, but finally they never needed it. And maybe there you may avoid to give immunotherapy in patients that would be prone, or that would have a high chance of toxicity. So there, yeah, I believe it. We're not there yet, but I think we'll have more, yeah, the biomarkers. And second, if our trial is positive, we might find also biomarkers that show that you can change the diet, and maybe you need to eat during 30 days, 30 vegetables per week, and to prepare your microbiome and to improve it. Yeah, something like that might be really cool. And I'm sure there are other things that will come out of it, but yeah, these are the first things I think about.
Okay. And can the knowledge from the study of the microbiome can be extended to other areas of oncology? I'd say you mentioned some areas, but just in oncology or in medicine in general.
So yeah, in the article of McDonald, it's also mentioned that there is a less antibiotic resistant genes present in patients that eat a lot of plants. So yeah, that's something really interesting that should be looked at, I think, in the future.
And I suppose for final question, for any patients and caregivers listening to this, what are your tips on navigating cancer care?
Is to ask questions. Is to ask questions to the oncologist, and to follow your belly feeling and see if you have confidence. But because for me it's very important, and I see now I'm the caregiver, but if I don't have confidence, and it comes from both sides, it's very difficult to treat someone. So and if you don't have confidence, you should find someone else, and that's okay. I mean, you cannot deal with everyone. So as a doctor, you cannot deal with everyone. As a patient, you cannot deal with every doctor. Yeah. I think you should really find the best match for yourself, and follow your feeling on that. Yeah, I think that would be yeah.
Great. Thank you very much.
Yeah.
Very good. That was great.
Yeah.